Okay, so we're going to roll right into to Dr. Clint Flanagan, who's one of those kind of rare animals that, yes, he was also very early in DPC, was also one of those rare animals that had a vision that he wanted to have impact beyond his own clinic, and ran over the last several years to build one of the larger kind of affiliate networks of direct primary care physicians that serve both consumers and employers. And he'll be taking us through that journey. Dr. Clint Flanagan.
Thanks, everybody. This is been on the DPC trail for a long time. And for like one day and packing everything they packed into here is pretty darn impressive. I don't think I've ever seen that before. And it's different, right? Not better, it's different. So I guess where I'll start, guys, is just a total disclaimer that when we started down this pathway in about 2009 or so, I had no clue what direct primary care was. And been a fee-for-service family medicine doc in Colorado for many years. I'm also an emergency medicine doc, and I just knew there had to be a better way. We saw the problems, as we do in primary care. We're right in front of our face. And kind of the dirty little secret that they don't tell you in med school and residency, as you have typically about 1 week of business, which I had in my third year of residency, is that you're going to learn all this stuff about disease state and how to take care of patients, and you're going to go out and you're going to go into a model that is really broken. In my pathway, it took a little while to figure that out. So I started in fee-for-service family medicine. I was with a multi-specialty group, about 50 docs, private group in Colorado, and we started on that pathway. And beautiful brand new clinic that I was in, seeing about 30 patients per day. It started at 0 because I was in a new, smaller town. We built that practice up with a pediatrician and a few others of us. And quickly you kind of learn as you get out of residency that you learn about this fee-for-service model because that's how you make a revenue. But it's kind of perverse. And you get on this treadmill here and you're seeing 30 patients per day or so. 30 to 35 is what I was seeing. And you just figure out that, my gosh, this is not what I signed up for. It's not what I signed up for a physician. This isn't what I spent the last 10 plus years or so of my life to get to. There's got to be a better way. So we looked around and understand this is back in around 2009 or so, and we didn't see a lot of solutions that were appealing to us. What we knew for sure is we didn't want to be looking through the otoscope into the insurance man's ear while he was looking at our patient. We wanted to be engaged directly with our patients. And so we said, gosh, why don't we just do monthly membership health care and make it affordable? We want to make it appeal and make it affordable for everybody in the community. So we had already had a pretty good, early on, business in that multi-specialty group. But I also kind of realized that as I was getting ready to be partner with that multi-specialty group that there was so much admin there that they were getting in the way of patients as well. So that led to, well, let's just start our own fee-for-service medical practice. And then through that process, I was also continuing to do emergency medicine. And all these people around 2009 or so, 2010, coming into the emergency room to see me. And when you see me in the ER, I'm a really high-dollar doctor. When you see me in a primary care, I can be really, really affordable. And about 50% to 70% of ER visits are primary care visits, but people just don't have their physician. They don't have their mid-level provider. They don't have anybody, so they come to the ER. So we said, let's just create a model and let's not be dependent upon insurance for payment. Because really, who's the payment with? The payment's with two people. It's with the patient and it's with employers. So on that pathway, we started the membership model, once again, having no clue what direct primary care was about. And then on that, as we were working, we're like, holy smokes, there is this guy out in Seattle that's doing something that's pretty cool. And he's calling it direct primary care, and he has a lot of money from Bezos and Michael Dell, and those are really smart guys. And it just turned out that gentleman, Dr. Bliss, was coming to Colorado for an American Academy of Private Physicians meeting that we were attending. And we said, hey, listen, you seem to really know what you're doing. Can we buy you dinner and have some really good wine and hang out for a little bit? And we did that. And what that helped, it helped us solidify that we were on the right track. because there was a lot of risk, right? And the other piece on that pathway was we had, at the time, built a pretty successful fee-for-service practice. We had a lot of patients, thousands of them, and we didn't really want to let them go. We knew that the model wasn't right, but we had a lot of good relationships. And to let them go, especially in that smaller town, which is where one of our clinics was at, there would have been a ripple effect with that. And imagine that ripple effect with a new model, because they had no clue what direct primary care was. So we held on to that. And as we moved down that pathway, we also realized pretty quickly that while it's awesome to provide direct primary care for your retail or consumer-based patients or those that are in your practice, there's a huge piece of the pie out there that's employers. And one of those employers, Left Hand Brewing Company, which I had been a fan of for years and had been very familiar with them, we said, hey, here's what we're doing, and we'd love to take care of your company. And it was perfect timing, because they had a high deductible health plan, and their employees, they were in a place where they really didn't get any care, right? They had a bankruptcy prevention policy. They didn't really get any care. So the owner got it. Craft brewers are innovative. The HR person, she was innovative, and they said, let's go, let's do this. And that was about 5+ years ago, and they're still on NextEra Healthcare. And we go to employee health benefit meetings. We do Ask the Doctor sessions. And in fact, they're actually happy hour sessions where we have a pint, and it's a lot of fun. We're taking care of those guys, and they're way different than some of the other companies we take care of. They're plumbers and electricians and rocket scientists, et cetera. But that was very, very early on for us. It was a really, light bulb kind of went on and said, hey, we need to go to employer groups. But the other piece was with that is while we had a few clinics and a few doctors, we realized that, hey, if we want to get some of these employer groups, they're going to want to have a female physician. They're going to want to have a male physician. They're going to want to have different locations. How do we do that, right? So we looked at, well, do we just take out a lot of money in some way, right, and just put clinics up, hire docs and put them in there? And we really studied that hard for quite some time. And then we said, well, there are a lot of great docs that are private family medicine docs, internists in the area. They have their own clinics, and some of them have been in these communities for years, in fact, decades. And we know that they are still surviving, right? But they're not thriving. They're, as Rob mentioned, their head's underwater, so at times. So we had we had moved far enough that we said, well, why don't we set up this network, this affiliate provider network, and we did all the legal blocking and tackling to make that happen. And let's go out and pitch them and say, hey, listen, you don't have to become a startup in DPC. You don't have to create your own logo. You don't have to create your own website. You don't have to take a lot of risk, which we heard about earlier. You can come on, and by the way, when you come on, we're not going to charge you a dime, because I felt personally that I didn't want to charge my family medicine physicians, et cetera, any money for that. So all that work that we had done for years, I just wanted them to come into our network, and there's value on many fronts there. That allows us to target these employer groups. Plus, it allows for that autonomy, right, that you heard earlier. It allows that existing family medicine physician or internist that owns their business and has worked really hard to build that fee-for-service business to still retain that. And then they can control the faucet. I want 50 new patients. I want 100 new patients. I want 500 new patients. And it's a little less risky, right? Just like it was for us in the early days, right? We weren't in a position where we wanted to go out and borrow $500,000 for our startup. And that's what we really, really were in the early days, because there wasn't a playbook that we could look at. We were kind of trailblazing. And so through time, years, this affiliate provider network has really worked out pretty well for us. And so when we go to employer groups, we can show that network. And one employer group we take care of, they said, hey, we really like what we're getting here in Colorado, but we have sites in Tampa, in Miami, and we have sites in the DC area. Can you take care of those people in those sites? And we ran out the door. Well, first we said yes. We're like, you bet. And we ran out the door. We're like, shit. We need to get ourselves some doctors in that area, And then we used this network, right? And particularly, I remember it was Lubin, Mike from Hint, and then Dr. Eric Crowell, and he's here today, and Dr. Hernandez, who's here today, which I didn't realize you were coming. I'm glad you're here. This was really awesome and super organic, guys, because you didn't have to put them through I call it next era healthcare boot camp. You didn't have to, tell them about the intricacies of direct primary care. And we'd had affiliates that we'd had to do that with because they were fee-for-service docs. But part of the beauty here is these guys were already doing direct primary care. They were experts in it, And what we said to them is, hey, we've got an employer. We don't have a site there. Can we make this work? And we won't charge you $1 up front. And we did the same thing with Dr. Matt Hayden out in D.C., who had his own direct primary care practice. And so, yes, we still have a fee-for-service practice. Okay. Yes, we love DPC, and we have zero interest in growing our fee-for-service practice. But that fee-for-service practice, interestingly, has given us the flexibility to do some very unique things in the direct primary care world. And while there are times in my day that I just want to say, we need to shut off that fee-for-service practice, I also realize that there's value in it. And in this landscape, you'll hear a lot of people say, never do a DPC. So your next question should then, never do a hybrid DPC. So your next question then would be, have you done it? Okay? Because if they're advising you not to do it, and they haven't done it, then you should ask someone that has been on that pathway, okay? Because that's a way that we can start to scale what we're doing here in direct primary care, because a lot of these docs, like we'll just say Dr. Smith that we brought on here a few years back, he'd been in the community for 20 plus years, so he just tremendous organic relationships. And to shut down that fee-for-service practice and go DPC only could be a challenge. I won't say that it's easier to do the hybrid. It could be more challenging, but we figured out, at one time there was no playbook that we could look at, and now we've kind of made our own playbook on this pathway. And through that pathway, just tremendous relationships with patients. So we're fortunate enough to be reminded every day in our practices as hybrid why we do direct primary care. Because you come out of one room and then you walk into a fee-for-service room, right? And the relationship's different. The relationship is at a whole different level in the DPC world compared to that fee-for-service world. But kind of living in both worlds a little bit has allowed us some pretty tremendous flexibility. And what do you see when you have that? You see what I think is most important in all this, and you see these relationships, and you see this care that is really what a lot of us physicians went to med school for, is to take care of people. And truthfully, in direct primary care world, we're not innovative at all in that arena. Where we're innovative is in the business model that supports that. And that autonomy can happen whether you're a DPC practice of one, whether you're an affiliate, or whether you're a network. I think one thing that we found out that's a little unique is we've done some experiments. So we, in our network, have, again, DPC docs that own their own business that come to us because they realize there's a lot of blocking and tackling that needs to happen to get those larger employer groups. Maybe they don't have the bandwidth on the marketing side, the legal side, the accounting side, the sales side, the biz dev side, and that's part of what we have said, we can help you out with that. And I would also say to the physicians in the crowd or so that say, maybe they're not the best businessmen or businesswomen in the room or in the world, I would disagree with you completely. If you have got your own practice, or whether it's a practice of one, or whether it's a practice of 30 docs, you've carved out your way, right? I mean, you don't need to have an MBA after your name to make that happen. You're paying your bills, and you're profitable. That's something you should pat yourself on the back for. And along that pathway, with what we've built, and at one time, remember, it was really pretty risky, and it still is a little bit risky, but much less. We're at a place now where we have a number of locations in Colorado, across the country. Number one. Number two, we have never taken out a loan to build what we built. Number three, I own 100% of the company. We have no outside investors in what we do. And we're at a place where we're providing just tremendous care for patients. And, it feels really good on many fronts. I see patients every day, Monday through Friday. I now take 2 half admin days, Wednesdays and Fridays, okay? So who better to create solutions and help move this model forward than physicians seeing patients that understand the fine details of what happens day to day. Will there be challenges? Will it be busy? Will there be stressful things? Sure. And I completely appreciate what you're saying, Bree. What I would say to that, though, is, I'll take that on all day long. Because remember, a lot of us have some battle scars and wounds and maybe a few stripes on our bodies from this old model, right? Where the head's underwater, and now we're in this new thing. So I look at that as any of those challenges that we see in this new world pale in comparison to this old world. And then the value that you provide in the relationships are so rewarding on so many fronts. So we're having a lot of fun what we're doing, guys. And it's great to see this type of summit, which says, hey, regardless of whether you're a boutique DPC, whether you're a network or other, what can we do to continue to scale this, okay? Because there's only a certain amount of people in that big pie that are the retail consumer. 85% of our membership's employer groups. And that's where things become a lot of fun, right? Because you talk for the same amount of time to sell what you're doing right, but instead you get 300 employees that sign up for you, and you can then get your beer at left hand for a much lower price. Anyway, so thank you guys for your time. I really appreciate it.